Good afternoon, everyone. Thank you so much for joining today's webinar. My name is Kate Morales. I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep United Coalition. We're really excited to present today's session on HBV Echo, Reducing Perinatal Transmission. So before we get started, I'd like to review a few housekeeping items and let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode, so you are muted during the presentation. If at any point you're having audio issues on your computer, there is also a phone-in option, and the call-in numbers are listed here. And you may submit questions at any point in writing during the presentations by typing them in the question box on your GoToWebinar control panel. We will be reviewing them as they come in and hold them until the question and answer period at the completion of all the presentations. And today's webinar is being recorded, so if you'd like to share this with your partners, you'll receive an email within the next few days with a link to view the recording as well as a copy of the presentation. And today's webinar is being presented by Hep United. Just to give you an overview of the coalition, this is a national coalition that was founded about 5 years ago by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. We are a coalition of over 35 organizations across the country, as well as hepatitis B community coalitions, with a mission dedicated to reducing the health disparities associated with hepatitis B by increasing awareness, screening, vaccination, and links to care for high-risk communities. The members of Hep United are community-based hepatitis B coalitions comprised of a variety of stakeholders, including health centers or health clinics, local or state health departments, community and social service organizations, as well as academic research institutes. We serve as a voice for hepatitis B advocacy locally and nationally, advocating for increased resources for hepatitis B prevention and treatment. And the coalition also co-brands a national multilingual communications campaign with the CDC called No Hepatitis B. So before we jump into the presentations today, we want to take a quick look at the state of perinatal hepatitis B transmission in the United States. Each year, an estimated 800 to 1,200 infants in the U.S. become infected with hepatitis B at birth. While this might not seem like a large number, 1 in 4 of these babies will die prematurely in adulthood of HBV-related complications, including or such as cirrhosis, liver failure, and/or liver cancer. We do have a strong foundation in the United States and tools for the prevention of hepatitis B transmission, and these include ACIP recommendations that all infants born to hepatitis B infected mothers receive their first birth dose of the Hep B vaccine, as well as a dose of the hepatitis B immune globulin within 12 hours of birth, or actually within 24 hours of birth now for the hepatitis B birth dose. And this regimen has been shown to be 95% effective in preventing perinatal infection. We also have an infrastructure, the Perinatal Hepatitis B Prevention Program. It includes routine screening of all pregnant women for hepatitis B infection. Perinatal coordinators are housed in local, city, and state health departments throughout the U.S., and they serve as a critical link ensuring that mothers and their babies receive the necessary services. So today, we're going to take a look at a new innovative strategy that is now focused on perinatal transmission and reducing perinatal transmission called HBV Echo. I want to go ahead and introduce all of our panelists to save time right now. So the first speaker is Dr. Iris Chen. Dr. Chen is a public health analyst in the Quality Division of the Office of Quality Improvement at the Bureau of Primary Health Care at the Health Resources and Services Administration. Dr. Chen received her PhD from Johns Hopkins University School of Medicine, where she researched HIV among Black men who have sex with men and conducted HIV and hepatitis C testing and outreach. Dr. Chen is the project lead for HBV Echo in the Quality Division, and she supports technical assistance initiatives for HRSA-funded health centers in HIV and viral hepatitis. Our second speaker is Dr. Carla Thornton. Dr. Thornton is a professor in the Division of Infectious Diseases at the University of New Mexico School of Medicine in Albuquerque, and she serves as an Associate Director of Project ECHO. Project ECHO stands for Extension for Community Healthcare Outcomes. She manages all of the hepatitis programs run out of the ECHO Institute, and through these programs, she helps train primary care providers and their teams how to comprehensively care for patients with viral hepatitis. So Dr. Thornton will go into more detail about the HBV ECHO and the Project ECHO curriculum. And finally, our third speaker is Dr. Amy Shen Tang. Dr. Tang is a primary care internist and hepatitis B program director at Charles B. Wong Community Health Center in New York City, where she oversees hepatitis B clinical care research, advocacy, and outreach. And she also serves as the Northeast Regional Director for the National Task Force on Hepatitis B, and she's the advocacy chair for the New York City Hepatitis B Coalition. So really excited for all of our panelists today and our expert speakers. And we're gonna go ahead and start off with Dr. Chen, who will provide an overview of the Project HBV ECHO program.
Thank you, Kate. I'm excited to have the opportunity to share information and updates today on HRSA's Health Center program and HBV ECHO, reducing perinatal transmission. So the Health Center program mission is to improve the health of the nation's underserved communities and vulnerable populations by assuring access to comprehensive, culturally competent, quality primary health care services. Health centers provide affordable, comprehensive, quality, and patient-centered care through a range of services. Our mission is rooted in increasing access for vulnerable and underserved populations. Currently, nearly 1,400 health centers operate more than 10,400 service delivery sites. In 2016, health centers provided care to nearly 26 million patients in every U.S. state, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and the Pacific Basin. That is 1 in 12 people in the U.S. and 1 in 10 children. Health centers serve 1 in 3 people living in poverty and 1 in 6 people living in rural communities. Among the 26 million patients served by health centers are more than 330,000 veterans, 2.7 million public housing patients, almost 1.3 million homeless patients, and nearly 1 million agricultural workers, and more than 750,000 patients accessing care at school-based health centers. The Bureau of Primary Health Care has 3 strategic priorities that guide our work to support health centers in delivering high-quality, outcome-driven care. These strategic goals are to increase access to primary health care services, advance health center quality and impact, and optimize Bureau of Primary Health Care operations. These strategies inform all our activities and are tied to our mission to improve the health of the nation's underserved communities and vulnerable populations. I'll talk now in more detail about the role of health centers in HBV ECHO, reducing perinatal transmission. HBV ECHO is a technical assistance opportunity launched in January of 2017 to assist HRSA-funded health centers in reducing mother-to-child transmission of HBV using the Project ECHO model. The National Viral Hepatitis Action Plan 2017 to 2020 calls for the elimination of mother-to-child transmission of HBV. Perinatal transmission of HBV is preventable through antiviral treatment for the mother and HBV prophylaxis and vaccination for the infant. Health centers provide many HBV-related services, including HBV screening, prenatal care, pediatric care, and childhood immunization. In 2016, HRSA-funded health centers tested 550,000 patients for HBV and served over 46,000 patients with HBV. These are both increases from 2015. Health centers are currently participating in HBV ECHO by meeting twice a month via video conferencing technology and accessing a web-based virtual learning community. During that time, health centers are presenting patient cases of pregnant women with chronic HBV infection to receive individualized case recommendations from HBV specialists. They share strategies for managing at-risk women and children, and they also participate in discussions with leading HBV experts on HBV testing, treatment, and management for pregnant women and their families, and cultural and systemic barriers to care for Asian Americans and Pacific Islanders and African immigrants and refugee communities. These are populations that are at high risk for HBV in the US. Over the past year, some of the curriculum that HBV ECHO has covered includes HBV epidemiology, testing and treatment recommendations, interpreting test results, and the efficacy of clinical interventions to prevent perinatal transmission. Health centers have also learned how to develop care plans for pregnant women at risk of perinatal transmission and strategies for vaccinating infants. Finally, health centers have learned various social, cultural, and systemic barriers such as cultural beliefs and stigma about HBV, strategies for patient education, and systemic challenges for immigrants and refugees. So I'm now going to turn this over to Carla, who will provide more detail about the Project ECHO model and HBV ECHO. But here's my contact information for anyone who has additional questions after the webinar. Thank you.
Great, thank you so much, Amy. I'm sorry, Iris. Okay, hello everyone. I'm really excited to talk to you today on this webinar about hepatitis B ECHO, and I want to do a couple of things today. I'm going to I have a couple of objectives. I want to talk about basically about why ECHO started and how it started, and introduce you to the basic principles of the model. And then I'll do a little bit more description about the HBV program itself. And thank you, Iris, for describing the goal of the project. So ECHO, as Iris or Kate mentioned, stands for Extension for Community Healthcare Outcomes. And really our goal overall is to move knowledge instead of patients. And I'm going to talk a lot about what that means, more about what that means. So Project ECHO started in New Mexico around 2004. It was really the brainchild of a hepatologist here named Sanjeev Arora. He was in New Mexico treating hepatitis C. And for those of you who don't know anything about have never been to New Mexico, it's a very large geographic area with a low population density. We have very few healthcare providers in many parts of New Mexico, and essentially no specialists in the majority of the areas in New Mexico. At the time that Project ECHO started, there were more than 35,000 reported hepatitis C cases of antibody positivity to the Department of Health here, but none of them had really, we didn't know much more about them. We just knew that there were 35,000 people with hepatitis C, and less than 5% of them had been treated. We also have the highest rate of chronic liver disease and cirrhosis in the nation. So Sanjeev, during 2004, was really the only dedicated hepatitis C clinic in New Mexico, and he was really trying to figure out how could I potentially solve this problem of getting access to care for hepatitis C patients. And as many of you may remember, at that time, hepatitis C treatment was just pegylated interferon and ribavirin, so there were no oral therapies available. It was very difficult to treat, and it was very toxic medication. The good news about the treatment at that time was that it was curable in about 50% overall of patients that we treated. The bad news was that it was very, very difficult to use the medication. There were severe side effects, anemia, and all of the patients. People would develop profound depression, sometimes neutropenia in a lot of patients. And at the time, at least to our knowledge, there were no primary care clinicians treating hepatitis C. So again, he was trying to think of how could I potentially figure out how to get the knowledge to treat hepatitis C out into the rural parts of New Mexico. So he developed this Project ECHO, and really the goals at that time were to develop the capacity to safely and effectively treat hepatitis C in all areas of New Mexico and to monitor outcomes. And he felt like if he could do this with hepatitis C, that it was possible that we could also do this with other diseases, and I'll talk more about that as well. So the ECHO model is very simple. Actually, this is of all the slides, this is the slide that this is the most important. It just talks about the methods of Project ECHO. And as I mentioned, and I'll talk more about the case-based learning, but the idea that Sanjeev had basically was that he tried to think of how did I learn how to do complex things when I was learning when I went to medical school or when I went to residency. And he said the way I learned is that I would take care of patients. I would go to my mentor. I would do a case presentation. They would give me feedback, and then I would go back and see the patient myself and do this over and over and over again until you actually become proficient in what you're doing. And so that he thought that this is really the only way that I can teach people how to do this use these complex medicines for hepatitis C, is to really develop a mentoring relationship with people. So the methods behind the ECHO model is that we use technology to leverage scarce healthcare resources. And for hepatitis C at the time, the scarce healthcare resources were people who knew how to treat hepatitis C, so the specialty knowledge and expertise. And really that was, for hepatitis C, it was someone who knew how to treat hepatitis C. We also used we used a psychiatrist in our clinic because of the complications with interferon, and a pharmacist who knew a lot about hepatitis C treatment. And so she's been involved from the very beginning. So the multidisciplinary team to treat hepatitis C. We also share best practices by reducing disparities, by reducing variation in care. That's one of the very important parts of Project ECHO, is to try to follow best practice and give and provide evidence-based information and recommendations. Probably the most important thing about Project ECHO is that it is case-based learning, or learning by doing, to master complexity. It's not just a teleconsultation where people come on and they ask about a patient every time that they have a question. The goal is really to make people experts in whatever you're doing ECHO about. So to make people experts themselves in hepatitis C, and over time they will be mentored by us and learn how to treat hepatitis C on their own. And then we have a web-based database that we monitor outcomes, at least for hepatitis C at the time. So again, this is really the model. On the left, we have the ECHO multidisciplinary team, the ECHO facilitators. We call this the hub, and we're connected on a regular basis, on a weekly basis, with our partners in the community, different types of partners. A lot of community health centers, they're the most common partners that we have. We also partner with Indian Health Service clinics and other clinics as well. And these would be called the spokes in the ECHO model. So the steps that we take in terms of hepatitis C is that we bring the hepatitis C treating team to our site in New Mexico. They learn about hepatitis C from us. They go to clinic with us for a day. It's really basically so that we can get to know them and teach them about our guidelines. And then we start to conduct what are called teleECHO clinics, and I'll show you a picture of what this looks like. So this is what a typical teleECHO clinic looks like. This happens to be the hepatitis C teleECHO clinic. And as you can see around the table, there's several gastroenterologists, myself, an infectious diseases physician, a pharmacist, a psychiatrist, a program coordinator, and there's also a physician's assistant who's an expert in hepatitis C. And one by one, our partners will present a case of hepatitis C to us. We have a case presentation form, so we get the information that we feel like is really essential for us to make good recommendations. And they'll go through this case. We'll discuss it as a group. We'll discuss it with the rest of the team on the teleECHO network, and then we'll give recommendations to the primary care provider on how to treat. In this picture, Raleigh Oden, who is an addiction specialist, is presenting a patient from, he runs an addiction center in Santa Fe, and is presenting one of his hepatitis C patients. And again, this is what it looks like from our end. We can see everybody come on at the same time, and when someone starts to speak, they actually, their picture will come up very large, and we can see them speaking. In addition to discussing cases, for example, in the hepatitis C teleECHO clinic, we talk about probably about 13 to 15 cases in a 2-hour period. And in addition to that, we give a didactic or a brief lecture, and I'll talk more about that with the hepatitis B ECHO as well. We want to make sure that people understand that ECHO isn't about just doing lectures. It's really about case discussion more than anything else. But if we find it very effective to have people learn also by the didactics that we give. I want to go back to this slide. So again, we start to conduct these teleECHO clinics, which we call knowledge networks, and then we initiate what we've sort of termed as learning loops, and I'll show you what I'm referring to. So the teleECHO, using the teleECHO model and having this collaborative group of people who are working collaboratively creates a really interesting atmosphere that is something I think that when he sort of came up with this idea that he didn't even understand how this would all work in terms of the relationships with everybody in the group, but it's a very interactive learning environment. So we do co-management of cases, learning by doing, learning from didactics as I described, learning from each other, and collaborative problem solving. And one thing that happens, again, which is different than just having a teleconsultation, is that people that aren't these specific subject matter experts will actually give their opinion, and we can collaboratively problem solve on complex medical issues or systems issues or anything that is discussed in the teleECHO clinic. So just to make absolutely sure that everyone has I'm sure you all do by now, but just to make sure that it's clear that teleECHO is very different from traditional telemedicine. Traditional telemedicine really overcomes the barrier of geography, and it's an amazing tool that is very, very helpful in certain situations. What it doesn't do, though, is increase the capacity to treat or in a community. So you're really doing a one-on-one with a physician to a patient, and ECHO really increases the capacity and the knowledge and expertise in the primary care providers at the site where they're treating. So what are the benefits to clinicians and teams? For every hour that anyone participates in a teleECHO clinic, they receive continuing education credits. People have told us that it really increases their professional satisfaction, that they can have interaction with colleagues with similar interests. They have less isolation, and we've heard from clinic administrators that it really can actually help with recruitment and retention. People have also told us that it creates a mix of work and learning. I think when people are, particularly healthcare providers in places where they feel isolated, they feel like they learn in medical school or whatever school they're going to, but they go out and they just work. And so this creates this where they have a mix of work and learning. They also have access to specialty consultation within the university for all of these things listed here. We really become colleagues and friends of everyone on these networks, and so they feel comfortable ask questions and calling us offline as well. So we had to do a couple of things to see if this model was really going to work. So the first thing we wanted to look at, after we found out that people really enjoyed it, which is what I was talking about in the last slide, did people feel like they could actually treat hepatitis C? So this is a study that we did. We surveyed providers who had been involved in hepatitis C echo for about 6 months. And as you can see, before participation and after participation for 6 months, they felt like they could identify suitable candidates, assess liver disease, and treat hepatitis C. They also felt like they had an improved ability to assess and manage psychiatric comorbidities, because of the interaction with the psychiatrist in the hepatitis C clinic, and they felt like they could educate and motivate hep C patients. Question number 5 was the most important question that we asked, which was, can you serve as a local consultant within your clinic in your area for hepatitis C? It's very important to understand that our goal is not to have everyone join an ECHO clinic. It really is for whoever sort of becomes the expert in that area in the primary care setting, that they can be a referral for all of their primary care colleagues. So after people liked it and they said they could do it, then we had to actually study to see whether it was safe and effective. And I'm not going to go into detail about this study. This was published in 2011 in the New England Journal. It was really comparing the outcomes of hepatitis C treated at our clinic at the university versus in community health centers and prisons. And it was a prospective cohort study, and the outcomes of this study were that it was exactly the same cure rate in both of in the primary care setting and at our clinic, and the safety was exactly the same. So again, I'm not going to go into details, and I'm happy to share this study with anyone, but it really showed us that people in the primary care setting could treat, even with this very toxic medication, safely and effectively with appropriate mentorship. So after ECHO had been in place in New Mexico for a while, we went from treating about 100 patients a year in our own clinic to treating over 1,000 patients with our Project ECHO partners. So after hepatitis C was very successful, a lot of people got very interested and started doing other diseases. The first echo to come out of after the hepatitis C echo was an addiction echo. So that was, there's several that have been going on for a very long time. There's the addiction echo, chronic pain, a bunch of other different echoes. We said what makes sense to do an echo? What kind of disease does it make sense in? It really has to be something that's common. The management is complex, and the other things listed here, it really has to be something that people need help with. It has a high societal impact, and you can make a difference when you actually treat the disease. So echoes expanded dramatically over the last, particularly over the last 3 or 4 years. There are now over 147 hubs, which most of them are academic medical centers, but some of them are also community health centers who run their own hubs. Echo is being applied for over 50 health conditions, and also some sort of novel things that it's being used for now for antimicrobial stewardship, where the hub is an academic medical center, but the spokes are critical access hospitals where they need help with antimicrobial stewardship. There have been very successful quality improvement type echoes. There's probably the most novel echo is called the crisis intervention echo, where the hub is police detectives and a psychiatrist and very experienced police officers, and the spokes are younger police officers who present cases about when they have difficult de-escalating violence. So that's been a very interesting use of the echo model. So this just shows you that these are all of the blue dots are hubs all over the United States and all over the world that have been that are replicating the echo model in 50 different disease states and some of the other things that I mentioned. So I want to talk briefly about, as Iris gave you a very good introduction to the Hepatitis B ECHO program. And as she mentioned, we started this in January of 2017. We've held 19 teleECHO clinics. We've had 32 unique participants and an average of 10 participants per clinic. And the red dots here are our spokes, so they're HRSA-funded health centers. And when I was talking about Hepatitis C ECHO, this is a very regional ECHO, and it's only in New Mexico that we run here. But as you can see, the HRSA-funded Hep B ECHO is national, because hepatitis B is not all healthcare centers have a lot of patients with hepatitis B, so the health centers that we do work with are ones that are impacted by hepatitis B. And as Iris mentioned, the three things that are the components of the HBV ECHO, we do case presentations, and Amy will talk more about that. She's going to give you some examples of things that we've discussed. We have a brief lecture during the hour and a half that we run our Hepatitis B ECHO. It's a very diverse curriculum, as Iris mentioned. We've had an amazing presenters from all over the world who are really experts in their field. And then we also have a virtual learning community, which I'll talk about. This is just a sample of some of the talks, and some of the 4 talks that we had last year in 2017 before we started our new year. But optimal HPV management in pregnant women, barriers to addressing Hep B in African immigrants and refugee communities, and consideration for postpartum flares were these four talks. In terms of the virtual learning community, it's been very interesting. We have offline discussion and messaging. We have clinical resources that are discussed during the teleECHO clinic. And also the didactic or a brief lecture that's done in the teleECHO clinic is recorded. And so the video recording of that talk also goes on to the virtual learning community in case people aren't able to be there for the teleECHO clinic itself. We also have a lot of hepatitis B guidelines that are publicly accessible, but we put them all in one place, and relevant literature so that people can access things in one place. So who should get involved in Hep B ECHO? So any HRSA-funded health center in the United States who services clients with HBV, we feel like this is a really amazing learning opportunity. We've had now the experience since January, and it's been like I said, a very amazing learning opportunity for everyone, I think, and Amy can speak to that as well. We are very interested in recruiting more HRSA-funded health centers, because I think that we're trying to still recruit new people to get involved. We think there are many other health centers that could potentially benefit from being involved in HBV ECHO. So if you want to get involved, you can send us an email at hbvecho@salud.unm.edu, and you'll have access to these slides. You can also go to the website and register, and we'll get in touch with you at that point. So again, I'm very excited to share this model with you and please, if anyone is interested, please contact us, and we would be very interested in talking to you. And thank you very much. And I'll turn it over to Amy.
Thank you so much, Carla and Iris. So before we move on, I wanted to just remind our audience members, if you think of any questions during the presentations, please do feel free to submit them in the question box, and then we will read them out after Dr. Chang's presentation. So go ahead and turn it over to Amy.
Hi, everyone. My name is Amy Chen. I'm a primary care internist first and foremost, and then also the Hepatitis B Program Director at Charles B. Wong Community Health Center. We're a federally qualified health center in New York City, and we have sites in Manhattan, Chinatown, as well as Flushing, Queens. So we see a very high-risk population for hepatitis B. And just to give you some more background about us, we actually have a Hep B registry of over 8,000 patients. So we actually end up seeing Hep B as commonly as we do diabetes and hypertension, and we manage it all in our primary care setting. We have internal medicine, pediatrics, and OBGYN here. So in terms of our Hep B programs, it ends up being very multidisciplinary, especially when we're managing mothers or pregnant women with hepatitis B. We end up coordinating between all different providers. So the cases that I'll be presenting today are all in pregnant women with chronic hepatitis B that are followed at our health center in our Hep Moms Program. My goal is to sort of illustrate that even though the guidelines for perinatal hepatitis B management is pretty simple, there is a lot of complexity with these cases, and we've really benefited from a lot of the rich discussions that have gone on in these twice-monthly clinics. Okay, so starting with our first case, this is a 25-year-old woman who screened positive for hepatitis B surface antigen at her initial obstetrics appointment for her very first pregnancy. So she did not know about her diagnosis previously. So her initial baseline labs were drawn at 10 weeks of her gestation of her pregnancy, and she had a very high viral load, undetectably high, greater than 170 million international units. She was e antigen positive, and she also had elevated liver enzymes with an ALT of 93 and AST of 50. And then here are some of her other serology or other lab tests. So our question for her was not so much whether she required medication, which she clearly did, given the high viral load, to at least reduce transmission to her baby, but also about timing of initiating her medication, because the medications that are available, namely tenofovir difumarate, does have some side effects, potential side effects on the baby in the womb. And so we wanted to sort of gather more information from the teleECHO clinic participants about what kind of things should be discussed when we go over risks and benefits of medication starting in the first trimester versus waiting until the third trimester. And then also, if she wanted to breastfeed, should she continue while she was breastfeeding, and what were some of the risks and benefits? And ultimately, even though there are hypothetical side effects on the baby, the registry data for pregnant women hasn't shown any. Has shown that tenofovir is actually very safe during pregnancy, and that also includes data from HIV patients. So this was all useful information when discussing management for this patient, and ultimately we did start her on medicines during the first trimester with plans to continue throughout her postpartum period, and she of course was linked to care with our internal medicine doctors who would manage her after pregnancy. Our next case is a patient who had already been following in our health center in internal medicine for her chronic hepatitis B. She had what we call inactive chronic Hep B, in that her e antigen was negative and she had a low viral load and also a normal ALT. So when she became pregnant, we were routinely monitoring her labs and happened to discover that she had cleared her Hep B surface antigen, which happens in a small subset of those who are e antigen negative. About 1% of folks will do that on their own. And so The issue is that she actually still had detectable viral load at this point. And so our question to the teleECHO group was, should this patient still get HBV for her newborn at birth, even though she was surface antigen negative? And so the discussion actually, there were people who had opinions on both sides. In general, her risk for infecting her child was very low, given how low her viral load was, and even the regular Hep B vaccine that's given at birth alone without the HBV would probably have been sufficient for reducing her risk of transmission. However, there were also people on the teleECHO clinic who felt that there was little harm in giving the HBV vaccine at birth, and that it should involve a discussion with the patient. However, of course, this would have to be coordinated with the hospital, because if they see a Hep B surface antigen negative blood test, they would automatically not give HBV. So this was something that we ended up actually giving to this patient. And one of our pediatricians who works at our clinic happens to also be a hospitalist at that hospital where the patient's baby was delivered, and made sure that the baby did receive it, to make sure that, to minimize or essentially make zero the chance that her baby would get Hep B. Now the third case is a 28-year-old woman who also had inactive chronic Hep B, and she's also followed at our clinic. During her pregnancy, there was concern about her platelet count being in the 70s, or 78,000 per milliliter. And so our question to the group was that what's on the differential for the causes of her thrombocytopenia, and how should it be managed? Because in this young patient, we didn't automatically assume that it was related to cirrhosis. She didn't have any signs or symptoms, and all of her other blood tests didn't really indicate that she would have that, according to her FIV4 APRI scores and her imaging. And so we talked about the possibility of hepatitis B related immune thrombocytopenia, and which is actually something that we see fairly commonly in our clinic. So Hep B patients who have a low platelet level, even though they don't have evidence of cirrhosis. And so this patient ended up being followed with hematology with periodic platelet blood draws that were done every month, and coordinated with the primary care provider to make sure that it didn't dip down anywhere below 50, in which she would probably need treatment. So this was an interesting discussion of low platelets in Hep B patient, also during pregnancy. We also discussed some pregnancy-related causes of thrombocytopenia that we just keep in mind, like HELLP syndrome as well. The last case I wanted to share for all of you is a case of a 4-year-old woman who actually had IVF. She had known chronic Hep B with a high viral load and an ALT that wavered, and she in the past had been recommended treatment, but she had declined. So she became pregnant with a triplet pregnancy, and that was at the point that she became my patient. Initially, when I first saw her during her first trimester, she had a high viral load, greater than 200,000, and an ALT that was slightly elevated. And so this patient was very, very nervous about taking any medicine that could possibly sort of compromise her high-risk pregnancy, understandably. And so I presented this case on teleECHO, and when we checked a month later, her studies looked maybe slightly improved. However, she would still, fit the criteria to go on antiviral treatment to reduce transmission to her babies. So the question to the group was, what's the optimal timing of initiating medicine, especially since triplet pregnancies tend to not go to term of 40 weeks. They tend to deliver earlier, so we wouldn't necessarily follow the guideline of checking the viral load at 24 and 28 weeks and then starting medicine, which might be too late. So I think the consensus was that these patients on average need about 10 to 12 weeks to lower their viral load to almost undetectable, to lower transmission risk. So we ended up starting her antiviral much earlier. anticipating that she may deliver around 33, 34 weeks. She ended up delivering around 34 and a half weeks, and her triplets are doing well. So just to summarize our program for everyone, this is a handout that we give to our patients about what to expect during and after their pregnancy, and for the children, what vaccines to anticipate, to make sure that everyone gets case managed from beginning to completion of their post-vaccination serology test. And because we see so many pregnant women with Hep B, that we see a lot of nuance in some of the barriers and challenges for people getting care. One of which was infants getting taken to China under the care of grandparents while parents are working in the U.S. and potentially not completing their vaccination series, or not getting their post-vaccination serology test, or being exposed to grandparents who potentially have Hep B and getting transmission that way. So this is actually a topic that we ended up talking about during one of the teleECHO clinics, to just share some of our experience with this issue that is not uncommon. So I just want to wrap up and really encourage those on the line who are listening, who are at health centers, who do see some of these patients, probably not as often as we do. However, that's even more reason to join, because these cases can be prevented. There can sometimes be some complexity, and I myself, even though this is my job as Hep B program director, I've learned so much new information. I've really benefited from the discussion with a lot of other Hep B experts. I highly encourage anyone who's thinking about it to join our next clinic, which is in 2 weeks on the 28th of November. And I'm sure that Carla and Kate and Iris will share all that information with you all.
Great. Thank you so much, Amy, and thanks to all of our speakers for that really informative discussion about HPV Echo, and just, learning about real case examples of potential transmission of Hep B perinatally. So we'll now begin the Q&A portion of our webinar. So as mentioned in the beginning, if you'd like to submit questions to our panelists, please feel free to do so via the question box, and I'll direct them to the speaker. And we do have a few questions that came in during the presentation. The first question is for Carla. With Project ECHO, you do offer continuing education credits. The question is, can you clarify whether the credits are, which field of study the credits are for? Is it MD, PharmD?
Right, great question. So for this particular ECHO, it's different for some of the ECHOs. We do have pharmacy credits and nursing credits for some of them. For this particular ECHO, it's CME. So I guess, is that, okay.
Yeah, that answers the question. And then just a follow-up to that question, for the lectures that were presented on ECHO, if anyone in the audience is interested, would they be able to access those lectures if this is their first time hearing about HPV Echo? And I think it was the curriculum that you showed before.
Right, great question. So we basically, the virtual learning community, we want to keep it as a sort of closed community for people who are participating in the teleECHO, who have come onto the teleECHO clinic and participating. So it's not really open to the public. If somebody joins us and wants to be a part of the teleECHO clinic, then we will give them, after they've joined a clinic and we know who they are, then we'll just give them access to the virtual learning community. But it's not, unfortunately, something that we have that's open.
Okay. And then our next question is, I guess it's a pretty general question about, and any one of our speakers, if you have thoughts, please feel free to chime in. Is there a way to mass inform providers, whether it's primary care providers or OB or GYN providers, about reporting requirements? So I guess reporting of pregnant women who are infected with hepatitis B. Well, maybe there's an improvement.
Right. Amy, do you have any thoughts about that?
The question is, any way to improve education to providers about reporting requirements?
Correct.
Or is the question, are there reporting requirements?
I think both. If you can touch on both.
Well, I'm actually unsure if there's a requirement, but I know that a lot of big cities across the country do have a perinatal Hep B program under the Department of Health where they do track these cases. Definitely in New York City. I also believe in Philadelphia and probably in San Francisco, though I don't think that it's a requirement across the country. So if they live in one of these large metropolitan cities, then it's probably tracked by lab tests actually already.
I think you're right. I think I've seen, so to the person that asked this question, if there's a list of states that may have mandates on screening or reporting requirements, but as Amy said, I don't think that's across the board, unfortunately. And then our next question.
The other question, Amy, was just about how to improve education for massive providers for hepatitis B and perinatal hepatitis B.
Oh, well, I mean, it is a U.S. Preventative Task Force recommendation to screen all pregnant women with the Hep B surface antigen. So I think that I think that in itself is something that, you know, all at least primary care providers should be aware of, at least the bare minimum, knowing the USPSTF guidelines. So I think just reviewing that with everyone, since there is a lot of evidence to support that.
Thank you. And then our next question is, or a couple of questions are for Carla. We have a participant who is from Ghana, and he's asking, how can this be replicated in Ghana? He's very interested in joining this project.
Oh, that's a great question. So there's actually a couple of, I didn't mention this, but this, in terms of hepatitis B, this is actually the first hepatitis B teleECHO clinic. There's a lot of hepatitis C, which is the most commonly replicated teleECHO clinic. But there are now several projects in Africa. There's one in Namibia, one in Kenya on HIV teleECHO clinic. So they're really training primary care providers and nurses how to, you know, in the expert treatment of HIV. So if you're interested in learning more about those, we actually have a website. It's just echo.unm, University of New Mexico.edu. And if you go there, you can sort of see all the places where ECHO is being replicated. And also, you can actually see what the steps would be to try to replicate the model yourself. So you can start with our website, and also you can contact me directly if you want to know more about it.
And I just want to add, that would be wonderful to start a Hep B teleECHO in Ghana, as the Hep B prevalence rates in West Africa are quite high, and I don't think that there are a lot of resources going towards addressing that at the moment. So that would be a great initiative.
Yeah, I completely agree. This is Carla. I think, you know, HIV has sort of, there's definitely going to be, I think there's 6 or 7 HIV echoes that are being planned in different countries in Africa, because there's money, there's PEPFAR money, which doesn't, of course, as you all know, exist for hepatitis B. So, but it's just as much of a need as HIV, and certainly in Africa.
Right. And just a comment, I think also from someone that's overseas, related to this discussion, that teleECHO is really promising, especially in low and middle income countries. But prior to initiating this program, one of the barriers that this person is seeing is technology. As there is often just a need for basic technology requirements like computers and internet connection, which is not always available in more remote areas. or lower income countries. And I don't know if you wanted to comment on that.
Yeah, Kate, I can comment on that. So we know the first echo to start in Africa was this Namibia HIV echo, which started about 2 years ago, and that was a big concern when it started. But so we use a technology called Zoom, which is a video technology, very, very easy platform to use. And a lot of people join in Namibia from their cell phones with 3G or with 3G. So it hasn't really, I mean, there's also the internet connections are getting better and better, but it did not end up being a huge problem from a technology standpoint, because the software you need and the connection you need is just not that, you don't need a lot of equipment, and you don't necessarily need high-speed internet. So,
right, that's a good point. Thank you. And then also related to just the setup of ECHO, is there a cost to join?
From the health center, no, there's absolutely no cost to join ECHO. And the ECHOs around the country, basically, they're free to the participant, to the spoke. And
all they would have to do is email you with interest to join, as
absolutely.
long as they're a federally qualified health center. Okay.
Exactly.
And this question is related to a case study, and also something that I wanted to ask as well. You know, as you're discussing these case studies, specifically looking at pregnant women who are infected with HPV, do you end up following these women, pregnant women postpartum, these types of cases, discussing them, and what insights have you found in terms of managing their case postpartum, and are they added to the prevention hepatitis B, not prevention, or hepatitis B programs, adult hepatitis B program?
Yeah, at our health center, we follow them postpartum in our internal medicine clinics. But we are possibly unique compared to other locations. So we have a Hep B registry, and then we also have two special Hep B programs. One is the Epi Moms Program that I mentioned that starts at the time of diagnosis in a pregnant patient with Hep B, and it ends at the time of the child, the baby born to that Hep B mom, getting their post-vaccination serology test, which is usually between 9 to 12 months of age. But after that, the patients often end up following with our internal medicine providers for their chronic hepatitis B care, because this is a chronic condition, just like diabetes and hypertension is a chronic condition, and people usually need to be followed every 3 to 6 months. So it's actually a pretty seamless linkage to care within our health center, but it could be a potential issue outside where people are often seeing specialists and maybe don't have a smooth follow-up with them. So yes, we definitely make a point to educate our patients that they need to be followed up afterwards, and we do have special programs. In particular, I didn't mention that our health center, our chronic hepatitis B registry, about a little more than 25% of those patients are uninsured. And so, as a lot of people might know, when a patient becomes pregnant, they do get temporary Medicaid. But when they're about 3 months postpartum, that Medicaid goes away and they're again uninsured. So we actually have a special program that's grant-based that helps pay for cost of lab fees and radiology costs for these patients with chronic Hep B who no longer have insurance.
Thank you. And Amy, I think this question is also for you. And it's will HBV administration be recommended to infants born to women who do test surface antigen negative? If not, what criteria would be considered to not administer HBV?
So if I heard correctly, the question is, should HBV given to babies born to mothers who do not have chronic or who do not have surface antigen positive. Is that the question? Okay.
That's right.
So our case was very unique in that it was a patient who had known chronic hepatitis B and who happened to have the Hep B DNA level checked when she had cleared her surface antigen. So because we knew about the DNA level, it was an option to just give the HBV, even though she was technically surface antigen negative. However, in a patient that you're screening, according to the U.S. Preventive Task Force guidelines, often most of these women are only getting the Hep B surface antigen, and so if that's negative, they would never end up getting the HBV vaccine at birth for their child. So, as a general statement, children born to mothers who do not have Hep B surface antigen positivity, who are not known to have Hep B, do not require HBV.
Great, thank you. Okay, and then yes, sure.
This is Carla. Sorry, the previous question. I just also wanted to point out that one of the really advantages of this hepatitis B echo or getting expertise to someone like Amy, who actually runs an amazing hepatitis B program for mothers there and can share her experience. And I know they see a lot more Hep B than a lot of people, but to be able to share their handouts, their process, all of that with other community health centers, I think would be great for other health centers who don't have as much experience.
Yeah, absolutely. And just to clarify, this is also a follow-up question from the audience, that you do have to be a community health center in order to join the HBV ECHO program or part of a community health center. And that's yes. And I guess in follow-up to that, Carla, how would you apply to be an ECHO hub, or how have people been proposing new diseases to be added to the Project ECHO program?
Yeah, that's a great question. So as I was mentioning for the gentleman from the person from Ghana, if you go onto the website, we actually have a whole process called ECHO replication. So anybody can basically use the model for whatever they see appropriate in their own institution or their own setting. And so there's a couple of things that have to happen. It's relatively straightforward. We ask that people come here and get trained basically, and free. We train people free of charge. We offer them access to the Zoom technology and things like that. So there's a process that's described pretty clearly on the ECHO website.
Great. Well, thank you so much. It looks like we are out of time for questions. And if there are any clinical questions that did come through, I will be sure to share them with our clinicians, and we will do our best to get back to you on those specific questions. I wanted to just thank everyone and our panelists, Iris, Carla, and Amy. Thank you so much for sharing your expertise with us today. This is a very exciting project. We've been waiting for very long to have a national program that is taking a closer look at why there are still so many babies being born in the U.S. We definitely see it as something that can be eliminated in this country. So thank you all so much for your work in addressing this issue. Like I said, if we weren't able to get your questions today, if you have any follow-up questions for any of our panelists, please feel free to email us. And I don't have it up here on the screen, but it's connect@hepbunited.org. And I will pass your questions along to our panelists. And after you close out of the webinar today, please look out for a message from the webinar service, which includes a survey on today's presentations. We would appreciate if you fill it out so that we can continue to improve our webinar programs. And please, if you're interested in joining the coalition, visit hepbunited.org. We're always looking for new members to join the coalition, as well as suggestions for other webinar topics that you're looking to learn more about. So thank you all so much, and have a great rest of the day.